Well, good morning, everyone. So I think I started doing this TLIF talk like 6 or 7 years ago. And at that point, the fellows were probably old enough to know what this movie is, but I don't know if you guys have any recollection. It's a Tom Cruise movie, Minority Report. Anyways, we'll get into it.
I've seen it a lot of times. Great movie.
Okay. All right, good. So then it won't be completely lost on you. So obviously, TLIF isn't something we do a ton of, but today we're going to go through the indications, pros and cons of various approaches to the spine for interbody fusion. We'll do some case examples and then go through some of the technical considerations. The AO spine actually has a nice chapter on like the exact step-by-step procedure, especially for MIS TLIF, which is really the only way that I do it for the most part. So you guys, I'm sure have seen this figure a million times. I won't spend much time on it, but there are various approaches to the interbody space. PLIF, I think, is fallen out of favor. I've never done a PLIF. I've never put in an interbody and not at least taken off the facet from a posterior approach. But back in like the 90s, I think that was sort of commonplace. And then you guys know very well the anterior and lateral approaches to the spine. So where I trained, it was essentially like MIS TLIF or bust. I think we did like 3 laterals my entire fellowship year. And again, this is like 9-10 years ago, but certainly at that time, like Bob and Greg were doing a lot of laterals, as were others, Bill Taylor and folks. And so lateral was around. It's not like it wasn't around, and they had the Maxis retractor and things like that. It's just that I think in neurosurgery in particular, and frankly, I mean, like 85% of the country at that point, just lateral was something that they didn't train with. So a lot of folks weren't particularly comfortable with it. As you guys know, not everybody has a great access surgeon for anterior approaches. So for a lot of surgeons, TLIF was kind of the workhorse. When I started my training, we did open TLIFs. So like Yusuf and I did a TLIF on Friday on a gentleman with a BMI 50. And to do like a 1-level fusion, an open TLIF for that, like the exposure and morbidity was crazy. So the advent of MIS TLIF, which was primarily driven by this gentleman, Kevin Foley, and then also Rick Fessler, who was my fellowship director there on the left, really did reduce the morbidity of the procedure. And you could still get a good fusion. And there are certain retractors that are like pedicle based now that are sort of like these hybrid MIS TLIFs where you put in the pedicle screws, and then you can attach these retractors to the pedicle screws. And I would say they're better than like the traditional midline takedown, but they're not really as minimally invasive as a tube. And the fact that the tube is round confers a number of benefits in the way that it retracts tissue and minimizes soft tissue destruction. So I think that if you're going to do a TLIF, unless there's a revision or some other good reason not to, that the MIS route is definitely the way to go. Obviously, if it's in the context of deformity or something else, it's a different animal. But presuming it's a degenerative 1-2 level TLIF, I strongly advocate for the tubes. So going from Rush to San Diego, like I got here, and that's kind of how I knew to treat spondies, how I knew to treat interbody fusion, and obviously that wasn't certainly like popular amongst this cohort. So I'd sign on to morning conference and be like, oh, here's my guy with like a spondee, and I did a TLIF, and I got a lot of feedback from these gentlemen. And it was sort of a learning experience for me. I mean, as you guys know, now I probably do 3 laterals for every TLIF, but it was kind of interesting to go from one dogma to another and to realize that there's a lot of heterogeneity in the way folks practice. Even today, like only, I don't know, they say 20%. My guess is it's more like 30%, maybe 35% of folks do laterals, but the majority of spine surgeons in America really rely on TLIF. So it's an important technique to get familiar with. So what are the advantages of coming from the lateral position? Well, obviously you can get a bigger graft. You can do that MIS. I think it does a better job of indirect decompression, which is important because you're not dropping a tube right down on the spinal canal. It's quick. It's definitely faster than TLIF, especially if you're doing multiple levels. Then it's way faster. You don't need to do, posterior muscle dissection. You can just put in the perc screws, but obviously it's limited, and the crest can get in your way, the plexus can get in your way. You are fortunate to have some mentors who can really show you how to push the limit and use techniques to make even difficult laterals at 4-5 safe. There are instances of bowel injury. I used to think that was something that really would only happen to a surgeon that maybe was not careful or didn't use 2 incisions or what have you. But a friend of mine who I know is a good surgeon, and someone who I operated with a bunch, had a bowel injury, so it can happen to even good surgeons, but it's rare. Sympathetic chain, similarly rare. You guys know 4-5 can be hard. Obviously, you can't do it at 5-1. I've not adopted the OLIF procedure. I think it's hard to take that on, or it could be hard, in terms of vascular access and stuff. And if you're going to need an access surgeon, then we obviously are blessed. I think an ALIF is still a really good procedure. And so, speaking of ALIF, obviously, I think in terms of lordosis correction, that's where the huge delta is. We've talked a lot about the benefit of lordosis from the lateral position as opposed to a TLIF. There is mixed data on that. There's actually some data that suggests it's not a huge difference. I think that has to be taken in context. So if you go and you get a banana cage way out front, and you take down the facets and compress, you actually can get a lot of lordosis with a TLIF. But if you just jam in a cage, it's like a kyphosis-inducing operation. So I don't know there's a huge delta between lateral and TLIF if TLIF is done appropriately, but ALIF certainly is in its own category in terms of lordosis correction, because you're taking down the ALL and you can put in a 20 degree and get pretty close to 20 degree and so forth. So ALIF is I think the best for lordosis. Obviously, you get the biggest footprint in there, more contact area, better fusion, less subsidence. Speaking of lateral and TLIF, not to go off on a tangent, but if the lordosis advantage of lateral is not baked in, the fusion benefit and the subsidence benefit lateral compared to TLIF definitely is a real thing. Let's see. Disadvantages, obviously, is that you have to have an anterior approach, and that can lead to vascular injury, retrograde ejaculation, ileus, these things that you folks already know. And it's in our institution, you can get to L3-4. In a lot of places, it's not such an easy endeavor, and even getting to 4-5, I think in some institutions isn't easy. Obviously, we're blessed, but you guys don't know where you end up, whether or not you're going to have that sort of ease of access to the anterior column. So, like I said, when I was in conference, these are the sort of the things that I would hear. You can't get sagittal plane correction, you won't get reduction, you can't get in a decent graft. Compared to lateral, that's probably true. You can't do it fast. I would say if you're going to do it well, that's true. You really can't do it fast. If you want to get a good disc preparation and you want to get those joints released, it takes time. Risk of CSF leak, that's true. Nerve injury, Yusuf and I are having a little bit of difficulty on Friday finding the exiting nerve root, just because it was like a 8 or 9 centimeter tube. I mean, the gentleman was really large, so it can be a little difficult to see the nerves. And sometimes when you're placing the graft through the tube, you don't have great visualization, and you can put some traction on the nerves. So that's an issue. They all subside, and most don't fuse. I mean, there is a subsidence issue. Most do fuse, although I would say that this is the one surgery where I still use BMP. I just use pure demineralized bone matrix fibers for ALIFs and laterals, and we've shown that to be effective and fuse at a high rate. But in MIS TLIF, I just don't think there's enough contact, even with bioactive 3D tie implants. So I still use an extra small BMP. But you can directly decompress the nerves, and you can do it MIS, and it's a single position. You get maybe a little more lordosis in the prone position. It's familiar for a lot of surgeons who are used to having patients in the prone position. You don't need an access surgeon. You're not going to get into a major vascular or bowel injury. But it's a small corridor, and we talked about the lordosis issue if you're not careful. Durotomies can be brutal, and I think subsidence can be an issue. So another thing that I think I learned early on, particularly because I was so hell-bent on trying to match the lordosis my partners were getting with laterals, is I'd put in these like first-gen expandable cages, meaning like a rectangular cage that has like a rigid mechanical expansion mechanism where you just dial it up. And if you put in, a rectangle that's covering a quarter of the disk space surface area and you really try to crank it up, it will subside. So I think the second generation TLIFs either have some kind of axial expansion mechanism or some other design element that tries to get to the apophyseal ring. A lot of them will torque out now so you don't overcook it, but it's something that you definitely want to be mindful of. And I like to generally expand under the under general fluoroscopy. So I take an X-ray with every couple degrees of expansion while I do the rest of the procedure using navigation. But I really think it's important to see, are you starting to get into the end plates? How much is enough? How much is too much? And so forth. So be careful about the expandable TLIF cages. They can subside. So this image, I don't know, guys, if you remember Minority Report, but the basic premise is that there are these psychics that can predict crime, and they usually all have the same prediction, and then it's like a good, I don't know, high positive predictive value that they're predicting like a true crime. But there's also this thing called the Minority Report where two of the psychics think one thing and then the third psychic predicts a third thing. And sometimes that third psychic is correct. So sometimes I think TLIF is actually indicated, is what I'm trying to express there. Sorry about that. Let me share my screen again.
I love the reference.
Thank you. I thought it was pretty clever. Wait, are you guys still seeing my screen? Or no?
Yeah, I'm seeing.
Oh, okay, sorry. It timed out for me for a second.
I want that slide.
You can have it, buddy. Especially with AI, it's kind of silly now. Like with AI, you can get such better. Okay.
This
cool.
demonstrates the human element.
Yeah. Right.
Sometimes it's funnier.
It probably took me like 40 minutes to do this back in like 2019 or whatever. But yeah, now I could have AI probably animate it. Okay. So speaking of my early experience, so where I trained, this is a great TLIF case. Now it's probably one I would do lateral. You can kind of see the psoas anatomy there, but it's also a good case for TLIF, and you can see that this is a patient that maybe does need a direct decompression. You'd have to get the history to know for sure, but it's possible, and has pretty severe foraminal and lateral recess stenosis. So you can see there, totally flat across 4-5 and very little at 5-1, like 10 degrees. So you can see my intraoperative X-ray, and I'm putting in one of those rigid expandable cages, and I got quite a bit of lordosis. So I'm like really psyched. I'm like, who says you can't get lordosis with TLIF? But if you look at that X-ray on the right and compare it to the one on the left, you're asking a lot of fairly little end plate coverage. And so I was like pretty psyched. They did one of these like featured cases or whatever. I'm like, oh my God, I'm like the best, And she did really well. But then in 3 months started having back pain again, and you can see why. And it just pretty dramatically subsided. And a lot of the lordosis that we achieved intraoperatively, when it subsides, is of course lost. Fortunately, it usually goes on to heal. This one went on to heal, but you're not getting the correction that you think you are intraoperatively. So if you look at the data on expandable versus transforaminal cages, as you might expect, subsidence is higher and quite a bit higher, like 1/5 compared to 5%. So expandable cages really do lead to subsidence, but I still think that it is something that you can do thoughtfully and not have that issue. So you just got to be careful when it comes to expanding, and certainly that can cause end plate violation during the expansion mechanism, which is what leads to the subsidence issue. You guys know that at Green we have great access surgeons, and mentors will teach you lateral. So even if you feel like you're on MIS TLIF Island, I think that there is a time for it to work. and there are certain disadvantages to the things that we do with anterior and lateral approaches. So this is an anterior approach, looks pretty good. This is actually one of my colleagues' cases, but he showed this at a course we did together, and this is something that we all know can happen. I think it was Tim who did a paper on this recently, where you've got some kind of osteophyte. Oftentimes it can be the superior articular process that can entrap exiting nerve root in the foramen. And I think this is particularly true if you really use a hyperlordotic cage. Sometimes you can get that SAP into the frame. And so obviously if you're doing a TLIF, you're taking all that bone down. That's one advantage, or at least one thing to be cognizant of if you're doing an ALIF. When that happens, oftentimes you've got to take the patient back and get a tube back in there and free up the bone. So one thing that's nice with TLIF that maybe confers a benefit, because you do see both the traversing nerve root and you can see the nerve exiting the foramen directly, and so you don't have to worry about that. So this is a lady who I thought was a good candidate for TLIF, and if you look there, you can see that she's got pretty horrific compression. Did not improve with recumbent position, and so a supine position. So she needed a direct decompression. If you look at her psoas anatomy, she's got that classic Mickey Mouse with the plexus migrating ventral, along with the psoas muscle. And she's got a relatively low pelvic incidence, and so it's not like she needs a ton of lordosis. So it seemed like a really good case for a TLIF in my hands. Usually when you see this picture where it's like 5-1 is totally spondylitic and you see the 4-5 spondy, not maybe usually, but oftentimes they've got some kind of like Bertolotti's or some other autofusion at 5-1. So a lot of the pressure is being transmitted to 4-5. That's, again, just speaking of Friday, that's what AJ and I were dealing with on Friday. And so, a lot of the stress is conferred to 4-5, almost like an adjacent segment. This patient had also had some abdominal surgeries, and then you can see the Mickey Mouse here approach. I was really trying to stick it to you, I think, when I put this together, Greg. So she also had osteoporosis, though, and so given the...
It's well received.
Yeah, good. Given the predilection for subsidence in a patient that has osteoporosis.
I feel like I'm at home with my boys. My boys are just constantly on me. This is like that. Yeah, I appreciate it.
So subsidence was an issue, and I wanted to get some correction because she was really malaligned. And so this is a case where we did bilateral facetectomies, and then I put in 2 TLIF cages to try to increase the surface area and allowed to get some lordosis, but also not subsidence. And so this is Ryan Hole, who was an awesome fellow. He's in Minneapolis now. And we'd done a couple together. That's when TLIF was really my workhorse. So he'd had some experience, and he could do his side and I could do my side, and we could kind of work together. And you see here the 2 tubes down simultaneously. It's not... There are a couple of learning points if you ever do try to do this contemporaneously, if you work with fellows. If you dock traditionally, you'll kind of just be running into each other the whole time, because usually it's a fairly lateral to medial trajectory. So you really have to try to go more orthogonal, or more just like take a kind of straight up and down plane, so that you can each get your half of the disc space sort of free and clean without just running into each other. And so after a little bit of trial and error, we were able to get that done and put it in 2 different grafts. And you can see sort of both grafts going in. You have to be a little careful with pre-packing as well if you're going to try to put 2 grafts in, because you don't have a ton of space, and you really got to do a good job with your disc prep. So we removed the pre-pack graft, and then we were able to get both cages in. This is this Flare Hawk implant. I haven't been using it recently, but it is kind of cool in the sense that it doesn't expand in sort of the traditional way. You put this little metal shim on the inside, and then there's a peak sort of shell that expands in an adaptive way. So it doesn't just rigidly expand like a rectangular, titanium graft. It kind of finds the surface anatomy of the end plate and expands in that way, which is kind of cool, and I think help with subsidence. That's what I'm trying to show here, just that the TLIF cage in this instance sort of adapts to the geometry of the end plate. And I think it was a nice implant. It worked really well for me. And that's sort of what it looks like. Didn't get a full reduction, but certainly helped the patient. And this is a better example of that after kind of learning that issue with getting too medial with our trajectory, coming in at a more orthogonal position and getting better position for 2 of those adaptive flare hawk implants. Another case, an 83-year-old woman, she had really bad bone, a bad spondy, and was even having bladder issues. So she really needed direct decompression, but again, had terrible bone. Also, really needed to get her off the table because she was an elder lady and just couldn't tolerate that much anesthesia. So obviously another case where a lateral approach would be difficult given the patient's psoas anatomy and need for direct decompression. And you can see there, I mean, sometimes the compression can just be horrific with a slip and arthritic changes to the facet joints. And so getting a tube down there, being able to drill it all off really does at least prove to yourself that you're doing the right, or doing a good job with the decompression. When I was maybe working by myself and the TLIF option wasn't appropriate, or the simultaneous 2 TLIF option wasn't maybe something I could do efficiently, you could certainly still just do 1. This is another instance of that adaptive geometry cage, and she ultimately did really well. So it can work. Obviously not excellent lordosis, but some improvement there, and at a minimum, really, in this 83-year-old woman, solved her caudal equina issue. I think this is the last case example. So this is a 53-year-old guy, had a foot drop and a bad disc herniation that you can see there. I think I did a disc herniation. I did a microdiscectomy. Then he recurred after this first microdiscectomy and had a recurrent disc that you can see there after making a pretty good recovery. But on post-op day 33, he had a really bad recurrence. So I did another microdiscectomy and again did well for a while. And then about 10 months post-op, he had a 3rd disc recurrence. And so I think you can get a disc herniation out from a lateral approach. You certainly can do it from an anterior approach. I mean, from the lateral approach, I don't think you see it. You just kind of hope that you can suck it back in. But if you go back in from a posterior approach to remove the disc, obviously you can see directly that you're getting that herniated fragment off the nerve root. And somebody with a neurologic deficit, it's sometimes nice to get that direct confirmation that the nerve is free. This is that cage that I used. I don't really use it anymore. I've tried to move towards getting banana cages way out front, but it was helpful for that that subsidence issue. And the expandable issue is nice as well, because sometimes, especially when you have like a lot of scar, you can't mobilize the nerve, and so you need a small graft to get past that adherent nerve. And some of these expandables have a really low insertion profile, which can be really helpful if they're scarred and so forth. And this is that gentleman's post-op x-rays. Okay, so we talked a little bit about those pedicle-based retractor systems. I did 1 or 2 like that. I do think it's better than a traditional TLIF, an open TLIF. It's also a nice kind of hybrid approach if you're not super comfortable using the tubes. But I would say the recovery is a little different, and I got a post-op CT for this guy for some reason, and I was just looking at like the muscle and stuff, and it's just a lot more traumatic than using the traditional tubular approach, which I already touched on, which I do think is a lot less invasive than those pedicle-based retractor systems. So what are some of the considerations? So this is just a small technical note. If you do it through a tube, try to find a tube that has this little offset or this little side cut, which I don't know if the next slide shows it better, but basically it allows you to drop your hand so you can get medial and get the contralateral disc and get the trajectory you want. If you have a large patient like the one we had on Friday and the tube doesn't have that open side cut, it can really limit you because you're sort of stuck to the degrees of freedom that the tube will allow. A lot of considerations with expandables. This one in the center bottom, when I was a fellow, my fellowship director was really into it. It was very finicky to say the least, but you could get a huge graft and it would kind of go in like a snake and then curve. And so it, I think, helped with the subsidence problem because you could basically fill the whole disc space, but it was really a little bit finicky. There are some other like axial expansion mechanisms that I think are cool. But I think if you get a pretty big graft in the front, that's probably the best way to get lordosis. And if you're thoughtful about how much you expand, then that can help with the subsidence issue. And this is just a graphic showing that technique that I employed before. I like using this implant for two reasons. This is the one we used on Friday. The main reason is that I can navigate the whole procedure, and especially when I'm teaching you guys, like having the microscope is super helpful, so I can see what you're doing. And if you're going to have the microscope in place, then it's hard to use fluoroscopy. So I think when I was training, the way I would do it is we do it under our loops, and then you just kind of use fluoroscopy to figure out where you are. But if you're doing it with your loops, like you can't really see what your fellow is doing. I had this like camera that was on my headlight, but it was so grainy, like Fessler couldn't see anything that I was doing. It was just like blind faith. So I like using the microscope so you guys can see, or so I can see what you guys are doing. But that also really helps, or that is much easier if you're using nav, because then you don't have to bring the x-ray in and out, which interferes with the microscope, and it's just fewer x-rays for everybody in the room. And I think you can get the cage right where you want it using navigation, which is pretty important. And then this graft has this little like snaggle tooth, which does help get a little bit more apophyseal ring coverage. And you can kind of angle it around the nerve so you can still get it in and get a bigger implant in place. So we talked about subsidence risk. We talked about pseudo risk. I think it's important that you're not using peak cages. You got to have some kind of more hydrophilic surface technology. The direct decompression is important because you're not going to get the same probably indirect decompression, but it's good when you've got reops and they're scarred and you need to do a direct decompression. And I started off with a 26 millimeter tube. I almost always use 22 millimeter tubes now, which means expandables are helpful because you just have such a small corridor. And if you're trying to put it in a big graft through a 22 millimeter tube, it takes most of your visualization away. Okay. So any questions from the fellows right now? Otherwise, I'm going to go through the actual steps. Cool. So these are, I didn't create these slides. They came from John O'Toole, who is one of the guys who I trained with when I was a fellow. I didn't necessarily go there to train with him, but I ended up learning a lot from him. And I basically set up the room the same way that he does. And he likes to use navigation as well. And he's a really smart guy. So I just wanted to credit him. So if you're not using navigation, then a good rule of thumb is like 2 finger breaths, or about 4 or 5 centimeters lateral, depending on the size of the patient in terms of where you want to make your skin incision for the MIS approach, so that you can kind of dock right on the laminar facet junction. I like using navigation. As you guys know, this is actually a picture when I was a fellow. You can see the old O-arm. And so using navigation, you don't have to kind of measure, and kind of have like a rule of thumb. You can actually figure out exactly the ideal skin incision. This is me doing that, figuring out where the laminar facet junction is. Once you get the tube down on the laminar facet junction, it's going to look something like this. Once you get the muscle plug off, so you should see a little bit of the lamina, so that you can kind of get into the spinal canal and release the ligamentum flavum. But you also really want to see the IAP and the SAP. So zooming in, this is sort of what you're looking at. Getting that IAP off is really important. So this is what it'll look like once you get the bone removed. And I usually like to start with just doing a traditional laminotomy, and then I'll take that laminotomy up to basically where I see the end of the ligament. Or if you're using navigation, you can, really figure out where you are. But you basically want to take all of the bone off, hemilaminectomy and IAP removal, from pedicle to pedicle. So when you get to the end of the ligamentum flavum, that usually means you can just come straight laterally, and that'll get you across the pars and kind of keep you below the pedicle of the level above and get you what you need. So you're drilling, you're getting that IAP off. Usually once you start to come lateral, you'll kind of feel it give and it'll be loose. This is the part where I think it's a little bit more challenging than others. Thanks, sweetheart. And getting across that pars is much deeper than you think. So you'll feel that you're drilling and it's not giving, but you have to get deep with the drilling laterally to really release the pars. Navigation can help with that as well. But you just got to keep drilling, feeling, drilling, and then eventually you'll get through that pars and the IAP will come loose. Some folks like to use the osteotome. I'm not a huge fan of it just because, there's an exiting nerve root there and that thing can be pretty blunt. It is faster. So if you're going to use the osteotome, I would just say make sure you do it under fluoroscopy or navigation. And you just have to make sure that you're kind of hugging the pedicle. So you hug the inferior portion of in this case, 4 pedicle, and the superior portion of the 5 pedicle. That should prevent you from injuring the nerve, and that'll also, very quickly release the IAP. So, okay, now you've got the IAP off, and you're looking at the SAP, and you essentially want to skeletonize the caudal pedicle. That's going to give you the widest corridor for your TLIF. So this part I like to do with Kerrisons because we use the drill, you can pretty easily drill into the pedicle below. And so if you use Kerrisons, it'll just more aptly allow you to sort of skeletonize the pedicle and create the largest corridor that you can. I prefer to keep the ligament down for this just because, risk of CSF leak obviously goes down if you're keeping the ligament in place. So I'm using Kerrison there. Now I've got the SAP sort of flush with the pedicle, and we're starting to see our window. Then I'll remove the ligamentum flavum. At this point, if you need a contralateral decompression, then I'll probably just windshield wipe my tube over so I can see that contralateral trajectory. You can also, if you're just using a single MIS dissection, you can really do a pretty good job if you spend some time releasing the contralateral facet. You just keep going lateral into the facet joint, and you can really kind of loosen it up to allow for better compression and lordosis. So if they need a contralateral decompression, I'll do that contralateral decompression. If they don't, I might stay above the ligament and then just burr out that contralateral facet so you can get that lordosis. So ideally, when you're doing this, you can see both the traversing nerve and the exiting nerve root. If they've got a bad slip, the exiting nerve root is oftentimes like right on the disc. It's in the same plane. You'd think it would be more superficial, but because of the spondylolisthesis, it's usually kind of in the same depth as the disc. You just want to be mindful of that when you're finding it so you don't injure it with a shaver or anything else. Now you've made your annulotomy, you start doing the discectomy. I think this is an important point. The shavers are the most efficient way to do the discectomy, no question. But when you use the shavers, it has a tendency to create this pathway and leave like 2/3 of the disc still in place. And you leave that superficial contralateral and deep ipsilateral disc unremoved, or the disc space isn't prepped there, which is probably part of the reason why TLIFs don't fuse as well as laterals. But if you airplane or windshield the tube, you can really see more and get more of that ipsilateral decompression. And then I like to use a downgoing curette to get just underneath the annulus contralateral, sort of push disc away and really make sure they're getting the cartilage prepped, and then you can remove the free disc fragments. I'm a pre-prep guy, or pre-pack guy, I should say. I don't like putting a bunch of stuff superficial to the cage. I'm always worried about getting some fragments of bone or something that could migrate back towards the nerve. Likewise, I don't like having a lot of BMP that's sort of close to the thecal sac and could cause radiculitis. So I generally prep the disc space. I'll put half of the extra small BMP in the cage, whatever's left, I'll pre-pack with autograft. I like to use the Lucan trap to just collect the bone dust while I'm drilling the facet joint, and then I'll put that in there with the extra small BMP before I put the cage, so it's not so close to the annular defect in the nerve tissue. This is just an example of that. Cage is in place. Depending on what cage you're using, position is important. Obviously, if it's a bulleted cage, I think it's nice to use one that has like oblique lordosis, so that the lordosis isn't off the sagittal plane, but rather in the sagittal plane. More recently, I've moved towards getting those banana cages way out front. So position is important. And then we mentioned the over to the top decompression. I generally do this before I put in the graft, just because I want to loosen up that contralateral facet, and I can do that at the same time. And okay, decompression is complete here. You can see the nerves, they're in good position. And then the screws. So I'll usually, as this image shows, because I'm using navigation, I'll put the contralateral screws in position. I will just put K-wires in on the ipsilateral screws. So I'll put I'll do like an all-tip tap, navigated, and then I'll create a virtual K-wire, and then I'll place K-wires into that cannulated pedicle trajectory. Reason being that if you put the towers in with MI screws, they'll often be in your way if you're trying to do tubular work. So the K-wires, you can bend out of the way, but you want to get the navigation you want to use the navigation when it's still high fidelity. So I'll at least cannulate the pedicles prior to the interbody work, but I'll just put in K wires on the side of the TLIF and then bend them out of the way so that they're not interfering. And that's sort of what you're seeing here. The contralateral screws are in, the ipsilateral ones just have K-wire localization. When the disc space is really collapsed, you can also use those contralateral screws to distract a little bit and show yourself a little bit more disc space to start getting the cage in or start getting the shavers in and so forth. So I do think putting the screws in contralateral has some benefit in case you do need to open up the disc space. And this is a picture of Ryan and I doing it. So we've got the TLIF in. Now we're putting in those ipsilateral screws under navigation. There's the end result. And I think that's all I have. This is my wife. And I think when I made these slides, I only had March. She's now much bigger than that. And I have 2 little girls, as you guys know. So that's all I have. And then obviously I can take questions or whatever. AJ, we had, you know, it kind of stinks for AJ. Like the first one that we did was like, the guy's BMI was literally 50. And there's like this huge, for whatever reason, like a 7-centimeter tube is like pretty reasonable. But as soon as you get to 8 or God forbid 9, it gets really hard. I think the reason for that is like the drill and all the instruments, like once you get past 7 centimeters, like they're not designed for that. So you're like writing an essay holding the pencil by its eraser. You know, you have to like choke so far back on everything that it's really hard to get good control. But he did a good job. You know, hopefully the rest of you folks, when you rotate, I know I'm not a huge TLIFer anymore, but hopefully you'll get at least 1 or 2 cases under your belt.
And have you ever thought about using modular screws? So you can just put your screws in and then pop the head on. That's got an extended tab.
I've thought about it and I've done it. The thing that the conclusion I ultimately came to was that the amount of time, and a thin person, I think it's actually a good idea, or it's a good, you know, it's a good technique. But the issue is trying to get the like modular tab back on the shank. I feel like it's just a source of frustration, particularly in bigger patients, and that ends up taking me longer than it does to just put the K wires and come back with the screws in over K wires. But I've tried that.
Your incision is, because I mean, it's such a, especially if you're a bit lordotic, like the incision is still a little wiltsy. You just have like different pokes through the muscle.
Yeah.
So it's essentially the same muscle real estate as a pedicle-based retractor or not? How's that any different? By stabbing the muscle for a screw at both sides, and then doing your tube that's got a 22-millimeter opening. And then, do you know what I mean?
Yeah, I think that the main difference is actually just the tube. I feel like the MIS tubular retractors, because you can dilate sort of sequentially the way that it respects the muscle, you'll still have a little plug at the base, but if you do a good dilation, you can spare most of the soft tissue. And the fact that it's tubular, when you pull it out, the way the soft tissue sort of
holds back,
comes back together. I think that's different than sort of having, you know, 2 retractors like this and 1 retractor like that. I just don't feel like the muscle recovers in the same way. At a month, probably no difference. But I think for that first couple of weeks, there's definitely a benefit to those tubular retractors, just in terms of soft tissue injury.
Yeah. Yeah.
Hey, Dr. Malone, I was curious, just from a lordosis standpoint, like take ALIF and XLIF off the table, but you know, how many cases in your practice are you doing like the contralateral release? And then are there any MIS TLIF cases where you say this needs to be an open TLIF, or like what would be like how much lordosis would you say like you could create with MIS TLIF is what I'm trying to say, to be harmonious with the patient's spine?
Yeah, I mean, I think you should kind of, in your mind, like come up with a number based off of their anatomy and then probably cut it in half, or like maybe 60%. It's still hard, even if you do the contralateral facet release. If their facets are like super sloppy, then you maybe don't need to spend that much time on the contralateral facet. But if it's spondylitic, it's really going to limit you. And I think, you know, the time that and the morbidity of putting like a separate tube down contralaterally can sometimes be a little bit prohibitive if you're working alone. But going over the top really limits that. And I've convinced myself that I can still loosen up step to step pretty good just by going over the top and really drilling it out. In terms of how much lordosis you can get, I don't think you're ever going to get more than 15. I think it's usually going to be more like 10. With those expandable cages, you can get 15 or more, but it's going to subside. You know, I just don't think there's enough surface area contact to really maintain it. I don't fully know, Ryan, and one of the reasons I'm so excited about like the efforts we've made to track our data, like from EOB with Insight, but just track those EOS X-rays is like to see not only what I get and have a better understanding of what I can get using different techniques, but like how sustainable it is, you know? And so like, what do I actually get with a TLIF using it this way versus that way? So I don't have good data, but I would say if you think you're going to get more than 15 degrees, you're probably not. And even that's hard.
I thought we actually like a reduction of the spine in our case. I was like surprised at how much we were able to get out of it. And then I think it was I think the patient's anatomy, I think it was somewhat he had kind of that concavity to his vertebral body, and our cage fit actually quite nicely in that. But I think it was important, like you said, to take pictures, you know, each step of a few cranks of the lordosis to make sure that you're not at plate. And so I think we like really scrutinized that each time we did a few turns. So I think that was really a helpful step as well. Yeah, I think that was the biggest patient that I've ever operated on.
Yeah.
So that was also fun.
But even in that like challenging case, like we took our time, right? And I think we were pretty thoughtful about how we did it. And, you know, I think a lot of the negativity around TLIF is not necessarily just the operation itself, but the way it's performed. And if you just try to like, you'll hear guys when you're out in practice like, oh, it takes you like 4 hours to do TLIF. I can do it in like 90 minutes. It's like, well, I can do it in 90 minutes too. You know, like it's not that I don't know how to put in screws. It's not that I don't know how to use a curette. You know, like it's just, it's if you're gonna really get a good disc prep and you're gonna try to make you know, create enough looseness to get some lordosis and stuff like that, it just takes time. You know, and that's okay as long as they're tolerating the anesthesia. You know.
Yeah, I think the prepping of the disc too is also, I think, because like you're used to ALIF, you're like, oh, I can see all the disc I need to take out, but this one's like a much more of a feel, kind of bring it into the center of the disc where you can then extract it. So, and then I was like surprised that even though I thought like they found a lot of it, there was still the amount left. So I totally agree with your idea that like, yeah, you could do a disc prep in 10 minutes, but you're going to be leaving a ton of it back behind. So
right, and like we've already created maybe a disadvantage, you know, by going TLIF instead of ALIF or lateral. So like it's worth spending 40 minutes with the disc prep because like, you know, that's, you want them to heal, right? So
yeah.